Hi, good evening, everybody, and welcome to this innovative and live YouTube session as far as subject of orthopedics is concerned. I hope all of you are doing well, keeping well, and all of you are pumped up for your examinations just 1 week away. So we thought that just before the examinations, we will talk about 25 important questions, 25 important topics. And what I have done here today is that these are all the questions which have been asked previously in the examinations. So we have just made a compilation, and the related choices are the ones which have also been put up in the question. So we'll discuss not in detail but briefly. A very good evening to all of you. Thank you for all your wishes. And you all had a mock test today, so I know and I'm sure all of you must be very tired, but let us make this session very interactive and very exclusive as far as orthopedics is concerned, and more importantly, very informative as far as your current examination is concerned. Okay, so before we start, first of all, I'd like to say all the best to all of you for your examinations, and all of you all the best for this session also. So here we go. Now, we have discussed several topics, so this is a bunched up thing, and we'll talk about these questions. So first question to all of you, and I want all of you to respond as far as the questions are concerned. So this is a 24-year-old male patient who presented to the hospital with history of pain, history of a discharging sinus from the right thigh since last 2 years. So 2 years duration, pain and a continuous discharging sinus. So after a thorough clinical examination by the doctor, x-rays were taken, bloods were done, and these x-rays show various important changes, right? So what are the important things? Now, so this is an x-ray of your femur, actually x-ray of the knee joint, which shows the femur, and you can see here, all of you, so a lot of bony changes. My question to all of you is, if you can zoom this slightly, I think it's better now. I wanted all of you to tell me what exactly is this pathological lesion. And I think we have 4 choices here. So sequestrum, involucrum, cloacae, and a periosteal reaction. So anybody who wants to attempt this question? Very good. Kapil has put a correct answer. Nadira has put a correct answer. So most of you have got this right. It is sequestrum. It is sequestrum. Now, see friends, chronic osteomyelitis is something which is asked almost in every examination in one or the other way. We know that any infection in the bone lasting for more than 3 months in terms of duration is chronic osteomyelitis. And of the various changes of chronic osteomyelitis, there is one important hallmark which suggests that this is an x-ray of chronic osteomyelitis, and as all of you have told, it is a sequestrum. So sequestrum is, as we had discussed earlier also, it is a dead bone which is surrounded by infected granulation tissue, okay? And as I told you in the class also, if we can spot a sequestrum in the x-ray, it is chronic osteomyelitis. Sequestrum is the epicenter of a chronic infection in the bone. And till the time there is sequestrum in the bone, there will be these continuous or frequent episodes of discharge or pus discharge from the patient's, say, affected area, which is through a sinus, and that signifies the process of chronic osteomyelitis. So most of you have got this thing done. It's a dead piece of bone surrounded by infected granulation tissue. This is the sequestrum, and sequestrum is what is visible here in the distal femoral metaphysis. Now, what are the other, quickly going through the other parts. So what are the other things which you can see in a chronic osteomyelitis? Involucrum. Involucrum is a reactive new bone formation. So what all of us can see here, क्या देख पा रहे हैं? Can you see this radiodense new bone formation around the sequestrum? This is what is called as involucrum. It's a body fights this infection, forms a reactive bone around this dead piece of bone. This is what is called as involucrum. Mostly, if there is a long-standing infection, we can also see small openings in the bone, and that small openings are responsible for a continuous pus discharge from the bone. These are called as cloacae. So these were the important terms which we associate with a patient with chronic osteomyelitis. So fantastic. Most of you have got this thing done. Absolutely right. So the answer here is sequestrum. Okay. Right. So the second question is the following X-ray, which all of you can see here. The following X-ray is which type of epiphyseal injury pattern? Which type of epiphyseal injury pattern? When I talk about epiphyseal injuries, I talk about immature skeleton, and a traumatic injury to an immature skeleton near the growth plate or the physis is divided, or you can say classified by Salter and Harris classification. Okay, so we've got a lot of answers here. We've got answers in, some people are saying type 1, some people are saying type 2. I would like to zoom this now. Forget about the choices. Tell me which type of epiphyseal injury is this? Knowing that if we can clearly identify that this is your epiphysis, okay, this part is your growth plate or physis, yes, and this is the area of metaphysis. And I have discussed with all of you that an injury pattern in which there is a involvement of both epiphysis, physis and metaphysis, all three, is classically a type 4 epiphyseal injury pattern. Type 4 epiphyseal injury pattern. Okay. Now some of you have written type 2. This is not type 2. Why? Because this is not type 2 because we see that there is also fracture of the epiphysis, which is not there in type 2. If I talk about type 2, it would be, suppose this is the growth plate and suppose this is your femur. A type 2 injury pattern will basically involve separation of the epiphysis along with this attached beak of metaphysis. So this will be type 2. But as you can see, there is no epiphyseal involvement. Since in this case, there is involvement of epiphysis, physis and metaphysis, this is a classical example of Salter and Harris type 4 epiphyseal injury pattern. And this is just an X-ray which I wanted all of you to see and understand. What is our examination question from type 4? Which traumatic injury is an example of Salter and Harris type 4 injury pattern? So if you have to remember just one from your examination, please remember lateral condyle fracture of humerus in children. Yes? Lateral condyle fracture of humerus in children is an example of Salter and Harris type 4 epiphyseal injury pattern. While the most common site for type 2 epiphyseal injury pattern is for distal or lower end of radius. And I will just color this part. What is this attached metaphyseal fragment called as? So somebody is asking all four. So yes, type 1 is just a separation of the epiphysis from the bone. Type 2 is separation with an attached portion of metaphysis, which all of you can see here. This is what is, this attached beak of metaphysis is what is called as a Thurston-Holland sign. Thurston-Holland sign, which is an example of, which is found in type 2 epiphyseal injury pattern. Type 3 is just the fracture or involvement of epiphysis and the growth plate, but not. So if you see, or if you want to look how type 3 looks like, so if you go into this, in type 3, you will have the femur which will be exactly the same. And you will have a fracture of the epiphysis. So, fracture of the epiphysis along with the involvement of physis is type 3 Salter and Harris epiphyseal injury pattern, and involvement of all three, which is epiphysis, physis and metaphysis, is a classical example of Salter and Harris type 4 epiphyseal injury pattern, type 4. Right? So, please remember Thurston-Holland sign seen in type 2. Please remember lateral condyle of humerus, a prototype for type 4 epiphyseal injury pattern. These are the most important two questions which come from this topic. Okay. Perfect. Now, the next question is, a 12-year-old boy. So the next question is, that is a 12-year-old boy presents with a gradually progressive swelling and pains in 6 months over the upper end of tibia. So remember the age group, 12 years, adolescent, gradually progressive swelling, not acute, not chronic, since last 6 months over the upper end of tibia. X-ray shows a lytic lesion, as all of you can see here, with a sclerotic margin in the tibial metaphysis. So what is the answer? Questions, choices are simple bone cyst. Simple bone cyst also is a lytic lesion with a sclerotic margin, but upper tibia is not the most common site for simple bone cyst. Proximal humerus is the most common site. Osteoclastoma, second choice, osteoclastoma or giant cell tumor is an epiphyseal lesion. Okay, so this is a metaphyseal lesion, so osteoclastoma does not fit into this. The third is Brody's abscess, which fits into all the criteria of a subacute osteomyelitis found in patients with a healthy defense mechanism. And Brody's abscess is classically defined as a small lucent or lytic lesion with a zone of sclerosis. And why what this zone of sclerosis is? Because the defense mechanism of the host does not allow this lesion to expand, So the answer here is his Brody's abscess, okay? It is Brody's abscess. And the last, Ewing's sarcoma. Ewing's is basically a metaphysio-diaphyseal lesion. In nowadays, it's basically a medullary canal tumor. It's a malignancy seen very commonly in the first and the second decade of life. A tumor from the round cells. So the answer here is Brody's abscess, an example of subacute osteomyelitis. So very good. I think most of you have got this correct as well. So all the best. This is very good. Next question. A child, I think we'll wait for this question to load up. All right. Okay. Yeah. So I think people are asking Ewing's diaphysis. Yes, Ewing's is very commonly seen in diaphysis. And sunburst or sunray appearance, I'll just tell you, sunray or sunburst appearance most commonly associated with osteogenic sarcoma. Okay. So this we will see. Right. So next question. A child 7 years of age presents with complaints of painless limp while walking. So child walks with a limp but does not complain of any pain. You take an X-ray, and I'll zoom this X-ray for all of you here. This is an X-ray of the pelvis. X-ray of the pelvis. You can see both sides, an anterior-posterior view of the hip joints. And what we have to see, all of us here, is, as all of you can see here, the involvement of capital femoral epiphysis. As you can see, decrease in height and sclerosis and fragmentation of the femoral epiphysis. This is a classical osteochondrosis of the proximal femur, which is what is called as Perthes disease, also called as a Legg-Calvé-Perthes disease. Perthes disease or Legg-Calvé-Perthes disease, which is an osteochondrosis of the proximal femoral epiphysis. So, what is a hypothesis here which states why do children between 7 years, 6-7 years develop this? Is because of a hypothesis which is called as a Trueta's hypothesis. Trueta's hypothesis, which states that there is a decrease in the major blood supply, which is lateral epiphyseal vessels. The blood supply decreases to the femoral epiphysis, due to which it starts developing changes of osteonecrosis, and this is what is called as a Perthes disease, independently described by Legg-Calvé and Perthes. So it's called as a Legg-Calvé and Perthes disease. Okay. What is slipped capital femoral epiphysis? SCFE or SUFE or slipped capital femoral epiphysis is in an obese patient. Sometimes the femoral epiphysis basically slips posteriorly, such that it causes an adolescent coxa varus deformity. Okay, so male obese patients, when the femoral epiphysis slips posteriorly and the angle goes in a varus, is what is called as a slipped capital femoral epiphysis or SUFE. Decreased blood supply not to the joint, Kapil, decreased blood supply to the capital femoral epiphysis. Okay, it's because it's like very analogous to avascular necrosis, what you see in case of adults. So decrease in the blood supply is one which causes this development of features. What is your Perthes disease? Okay. Now tuberculosis of hip we will not go into detail because this is nowhere very close. Tuberculosis of the hip I'll show you in a separate thing. Tom Smith arthritis. What is Tom Smith arthritis? Tom Smith arthritis is tuberculosis of the hip joint in infants. In fact, rather not tuberculosis, but acute septic arthritis of the hip joint in infants. What happened in very young children? When there is an acute bacterial infection, it causes rapid destruction of the hip joint. So you will sometimes have an acetabulum, okay, but in spite of, suppose this is your normal hip, femoral head, what happens in Tom Smith arthritis? It is this part of the femoral head which undergoes rapid destruction, as a result of which, when you see this patient, okay, you will have neck, but you will have a destroyed hip joint. You will have a destroyed hip joint. And what is Tom Smith arthritis? Better called as an acute septic arthritis of the hip in case of infants. Okay? Acute septic arthritis of the hip joint in infants is what is called as a Tom Smith arthritis. Tom Smith arthritis. Right? Okay. Now, next question. So, next question is an image which you have to identify, and there is an X-ray here which is, okay, I think all of you can see it now. Okay, so identify this X-ray, which is cervical spine lateral view and an axial view of the CT scan. And think about this, please. Think about this before answering. Think about this, everybody, before answering. This is an X-ray of the cervical spine. Think about this before answering, all of you, please. So, I think a few people have got it absolutely right. I think Srishti got it right. So, we've got Mr. Ghansham who's got it right. Dr. Ravi has got it right. So, what you see here. Now, as I tell everybody, count the cervical vertebra. So, this is your C2 and this is your C3. Yes. So, what we see here is that the second cervical vertebra has moved or translated in front of the third cervical vertebra. So, there is an anterior translation of C2 over C3, and along with this you see multiple fractures as far as the second cervical vertebra is concerned. This description classically fits in the description of hangman's fracture. So, hangman's fracture is described as it's a traumatic subluxation of C2, second cervical vertebra, over the third cervical vertebra, along with fracture of the second cervical vertebra. Okay. So, traumatic subluxation or listhesis of C2 over C3 along with fracture of the second cervical vertebra is what is called as a hangman's fracture. Now, so I think some of you have got it absolutely right. Now, for other students, I will quickly tell you what is a chance fracture. Now, if you remember, recall from our discussion in the class, if this is your vertebra, a chance fracture is one which goes right from anterior till the posterior. So, it basically involves all the three columns of a spinal vertebra, and this is also called as a seat belt fracture, chance fracture. It's a flexion distraction injury pattern involving all three columns from anterior to posterior. It basically opens apart. So, that's what is called as a chance fracture. Clay-Chauvelur's fracture, if you can recall, seen in a group of people which are involved in clay shoveling. So, as a result of this regular activity, they start developing pain in the base of the neck. So, fracture of C7 or T1 spinous process. Okay. C7 or T1 spinous process is Clay-Chauvelur's fracture. And lastly, what is Jefferson's fracture? And these are all the important spine fractures. What is Jefferson's fracture? So, fracture of the arch of atlas or C1. Fracture of the arch of atlas or C1. Fracture of the arch of atlas or C1 is what is called as a Jefferson's fracture. Fracture of the arch of atlas or C1 is what is called as a Jefferson's fracture. So, these are four important spinal trauma or injuries which are normally asked in the examinations as far as images are concerned. Okay? So, please remember the answer here is hangman's fracture. So, this is the answer here. So, answer here is hangman's fracture. Okay. Now, we move towards the next question. Okay. So, we move towards the next question. Now, a young doctor is asking how to differentiate C1 from C2. Now, C2 has an elongated vertebral body which is called as odontoid process or dens. Yes, so this is very easy. While C1, the vertebral body of C1 is the narrowest of all the vertebral bodies. Okay, so the next question. Let's go slowly. A middle-aged patient presents in the OPD with complaints of severe pain in the wrist around the region of radial styloid process with difficulty in performing activities of daily living. Now, clinical test which is done here is to diagnose which clinical condition. Okay, so yes, everybody, what is the answer for this? Anybody can tell me what is this test called as? What is this test called as? This is very good. This is excellent from someone. Very, very good. I think, yes, it is. So, pain around the radial styloid process, which is seen in middle-aged patients, also females and males both, is because of inflammation of the first extensor compartment tendons. Inflammation of the first extensor compartment tendons. So what we do, we ask the patient to make a fist, and with the thumb flexed, we basically hold the patient's wrist and medially deviate. So if there is an inflammation around the radial styloid process, the patient winces in pain. This is classical of de Quervain's tenosynovitis, which involves the tendons of the first extensor compartment, which are abductor pollicis longus and extensor pollicis brevis. So, abductor pollicis longus and extensor pollicis brevis tendon sheath or tenosynovial inflammation is what is called as de Quervain's tenosynovitis, one of the very commonly seen repetitive stress disorders. And the test which all of you can see here, which again I'll tell you, is basically close the fingers, flex the thumb and medially deviate forcefully, is what is called as Finkelstein's test. This is what is called as Finkelstein's test. Finkelstein's test. Abductor pollicis longus and extensor pollicis brevis. Okay. The other choices, what is a trigger thumb? A trigger thumb is because of a nodule formation in the flexor pollicis longus tendon at the MP joint, due to which a patient is able to flex the thumb, but not able to extend the thumb, okay? That is trigger thumb, also seen in trigger fingers. Carpal tunnel syndrome, all of you know, is compression of median nerve inside the carpal tunnel. So what are the tests for carpal tunnel syndrome? We have done Phelan's test, reverse Phelan's test and Durkan's test. So these are the three important tests, Phelan's test and, so tests for carpal tunnel syndrome are Phelan's test, reverse Phelan's test and Durkan's test, which basically checks the compression of median nerve. And lateral epicondylitis is what is called as, what is lateral epicondylitis is called as? Durkan, yeah. D-U-R-C-A-N-S, Durkan's test. What is lateral epicondylitis? It's called as tennis elbow. Lateral epicondylitis is called as tennis elbow. And you have a patient, because of repetitive activity, starts complaining of pain around the region of lateral epicondyle. Which tendon shows a degenerative tear in tennis elbow? Which tendon shows a degenerative tear in tennis elbow? Anybody who can tell me this? So Mudit is asking what is Durkan's test. Mudit, Durkan's test is basically to diagnose carpal tunnel syndrome when you basically press with your thumb, you press over the this transverse retinaculum, you press directly over the median nerve, and since the nerve is already under compression, it increases the symptoms. So that is direct pressure on the median nerve, which is what is called as a Durkan's test. Durkan's test. Okay, anyone who can tell me in tennis elbow? So please remember that the tendon which shows a degenerative tear is one of extensor carpi radialis. Extensor carpi radialis brevis, or ECRB tendon, is one which has a degenerative tear in tennis elbow, which has a degenerative tear in tennis elbow. Extensor carpi radialis brevis is the tendon which shows a degenerative tear in tennis elbow. And anyone who can tell me now what is the clinical test of choice for tennis elbow? So what is the clinical test of choice for tennis elbow? How do you diagnose tennis elbow? So patient comes with me and says, Doctor Sahab, I am having so much of pain around the lateral epicondyle region. What I will do, I will basically ask, knowing that lateral epicondyle is an area of common extensor origin, I will ask the patient to do active dorsiflexion. So forceful wrist extension against resistance. Forceful wrist extension against resistance, and this causes an increase in pain. What is this test called as? What is the name of this clinical test for golfer's elbow or lateral epicondylitis? Sorry, for tennis elbow. Very good. Sadaf has written. So the answer is, this is what is called as a Cosen's test. Cosen's test. Very good. Very good, very good. Mudit, very good. Jitesh, very good. Isha, very good. So all of you know this. Excellent. Cosen's test is the clinical test of choice to diagnose tennis elbow or lateral epicondylitis. Okay? Very good. Excellent. Okay. So, Cosen's test. Cosen's test. Very good. So, next question. Next question is, so the next question is, so the next question, okay. A 42-year-old male patient presented in the outpatient clinic or department with complaints of severe back pain since 3 months and not relieved by painkillers, not relieved by physical therapy. X-rays and MRIs of the patient were done, which are basically given in front of you. So most common site of spine which is affected by this pathology. Please try to read the question first. Please don't jump into marking answers. All of you, it's a request. Read the question once again. Please do not jump into marking the answers, all of you. A 42-year-old male patient presented with OPD with back pain since 12 weeks, which is 3 months, not relieved by analgesics and physical therapy. X-rays and MRIs have been done, are shown in front of you. So, first question to all of you, what is the diagnosis of this? What is this X-ray and what is this MRI telling you? What is the pathology here? What is the pathology here? Yes, what is the diagnosis here? People writing answers but not telling me. This is, I think Zach Knight, somebody has written, this is spot spine. This is spot spine or tuberculosis of the spine. You have one X-ray here which shows you decrease in the intervertebral disc space. Okay? A decrease in the intervertebral disc space, and MRI which shows a significant collection of pus what is called as a cold abscess, which is compressing the spine here. So the question asks you, what is the most common site in spine affected by this pathology? And very few of you have got this answer right. I think few of you, Sachin has got it absolutely right. I think Vikas has got it right. See friends, tuberculosis of spine is the most common site of musculoskeletal tuberculosis, and the most common region in spine which is affected is the lower thoracic spine. Around 42% cases of tuberculosis of the spine is seen in the lower thoracic spine. So the answer here is B. Answer here is B. Answer here is B. So please do not confuse. Thoracic spine is the most common site of musculoskeletal spinal tuberculosis or pot spine. Okay. So B is the answer. Cervical is the common site in case of children but not in adults. Thoracic spine in adults is the most common site. Most common site. Very good. From tuberculosis of spine to tuberculosis of the hip. This is a question which came in the examination last year also. The most common site of initial focus in tuberculosis of the hip joint. The most common site of initial focus in tuberculosis of the hip joint. Remember, tubercular arthritis or the tuberculosis of the joint starts as a synovitis or a synovial inflammation. So what is the answer here? The most common site of initial focus in tuberculosis. So people are writing. Khushbu, very good. Naimish, very good. Saif, very good. I think Akash, very good. Prince, correct answer. Sneka, correct answer. Dr. Rathore, correct answer. Sumbul is correct. So lots of people have got it right. Okay. Now, the most common site of initial focus in tuberculosis of the hip joint is this part. Is the acetabular roof. Okay. So, most common site is the acetabular roof. Second most common site is the femoral head. So, it is this region around the hip joint which is the most common site. Most common site is of the tuberculosis of the hip joint. So please remember, I put this question because this is a question which was asked in the last examination. So acetabular roof or roof of the acetabulum is the most common site where tuberculosis of the hip joint starts from. So it starts from the roof of the acetabulum, then it involves the synovium, it involves the femoral head, and then there are various changes. So stage of from synovitis to early arthritis to late arthritis to advanced arthritis. So these are the various stages of tuberculosis of the hip joint. Okay, so please remember, starts from the roof of the acetabulum. Okay. Next question. Next question. So next question. So a 10-year-old male patient presents with an elbow deformity, had an associated history of a traumatic fracture around the elbow 3 years ago, which was managed by plaster cast application. Plaster cast application. The most common cause of the elbow deformity shown in the picture below is, okay, now, okay, so I want to ask, what deformity is this? What is the name of this deformity? What is the name of this deformity? This is your cubitus. There is a definite decrease in the carrying angle. So this is a cubitus varus deformity. Yes, it's a cubitus varus deformity, a cubitus varus deformity. Very good. I think most of you have got this thing right. Appears like a long barrel gun. That's why this is also called as a gun stock deformity. Gun stock deformity. Okay, it's called as a gun stock deformity. Now, of these four choices, what you see here, which is the answer? Is it because of a malunited supracondylar humerus fracture or a non-union of supracondylar humerus fracture? Or because of a malunion of lateral condyle humerus fracture or a non-union of lateral condyle humerus fracture? Now, if you remember from a discussion in the class and the notes if you have gone through, cubitus varus most commonly in pediatric age group, as is written here, is caused by a malunited supracondylar humerus fracture. Malunited supracondylar humerus fracture, because if you go and remember the displacements of supracondylar humerus fracture, the most common are medial tilt, which is the one which is very, very important. So because of this medial tilt and displacement of the distal fragment, supracondylar fracture is, if you can recall from a discussion, it's an extra-articular metaphyseal fracture. So it will always unite. Har samay judega. But if these displacements are not corrected, it will cause malunion. And malunited supracondylar humerus fracture is one which causes a cubitus varus or a gun stock deformity, which is what we can see here. So, malunited supracondylar humerus fracture, or choice A, is the correct answer for this. You hardly see a non-union in supracondylar, so this choice goes out. You hardly see a malunion in lateral condyle humerus fracture, so this also goes out. And what is the remaining choice is non-union of lateral condyle humerus fracture. If you recall, this produces the other deformity which is called as a cubitus valgus deformity. This produces a cubitus valgus. Remember, a non-union of lateral condyle humerus fracture because of decreased growth on the lateral side and because of a relative overgrowth on the medial side, it keeps on drifting out and causes a cubitus valgus deformity. So, cubitus valgus and a stretch in ulnar nerve causing a tardy ulnar nerve palsy. Tardy ulnar nerve palsy. Okay. Now, somebody is asking me what is the treatment? What is the treatment for malunion of supracondylar? So, now remember friends, supracondylar humerus fracture, it's an extra-articular fracture, does not cause a functional problem, it's only cosmetic. So, the treatment of choice is a so you have a bone which is causing a deformity. So, you do an osteotomy. You do osteotomy, cut the bone and straighten it. So, it's the osteotomy which is done, it's called as a modified French osteotomy. Modified French osteotomy is the one which is the answer for malunited supracondylar humerus fracture. Okay. Please read and go in the examination for supracondylar humerus fracture. It's a very, very important. Remember supracondylar humerus fracture, most common pediatric elbow trauma, extra-articular fracture through the distal humerus metaphysis, most importantly posterior and medial displacements, yes, and important complications. Early, if you remember, I told you in supracondylar humerus fracture can cause a Volkmann's ischemia, and in late complications, because of repeated massage in supracondylar humerus fracture, you can have a myositis deformity, you can have this gun stock deformity, and in late cases, because of Volkmann's ischemia, you can have a Volkmann's ischemic contracture or VIC. So, these are the various the complications as far as supracondylar fracture humerus are concerned. And what is the traction which we use? What is the traction which we use in supracondylar humerus fracture when children comes with significant swelling and bad wounds? It is your Dunlop or Smith's traction. Remember that? It is your Dunlop or Smith's traction which we use. So Dunlop's or Smith's traction which we use in supracondylar fractures with gross swelling and bad wounds around them. So Dunlop's or Smith's traction. Okay. Now, the next question. Right. So the next question. Next question. A 14-year-old boy presented with complaints of pain around the knee region with no history of trauma. Blood tests done were unremarkable. X-ray shows a swelling arising from the distal femoral metaphysis. What is the most common cause for his pain? So please remember, what is the most common cause for his pain? What is the most common cause? So first, all of you have to see and tell me what is this lesion. So friends, a lesion from the metaphysis growing away from the center is an osteochondroma. Okay, it is an osteochondroma, also called as exostosis. And this is the most common benign bone tumor. Most common benign bone tumor, but not the most common true benign bone tumor. The most common true benign bone tumor is osteoid osteoma. Okay, this is the most common benign bone tumor. And incidentally, it remains in a lot of patients without them even knowing that there is a lesion inside. So when a patient presents to you in the hospital with a severe increase in pain, these are the various things can take place. Okay, a trauma can lead to fracture of an osteochondroma. It can cause inflammation of the neighboring bursas and bursitis. Rarely there can be cartilaginous cap increase in diameter causing malignant transformation into a chondrosarcoma, and rarely, very rarely, it can cause degenerative changes. So of this, what is the most common cause for the sudden increase in pain is because of a long-standing compression, and I think most of the people have got this absolutely right, is long-standing compression of the bursal sac. So bursitis is the answer, bursitis. So long-standing compression because of an osteochondroma is or results in bursitis, which is the most common complication of a long-standing osteochondroma. Okay? Okay. So the answer is B. The answer is B. Bursitis is the answer. Okay. Next question. Now, next question. Okay. Now, the given X-ray shows which characteristic X-ray appearance. Which characteristic X-ray appearance is this? Which characteristic X-ray appearance is this? Chicken wire calcification, onion peel reaction, soap bubble appearance, or sun ray appearance? So if I see, very good, all the students, I think all of them know everything now in orthopedics. All of them have absolutely got it right. This is an X-ray of a femoral giant cell tumor or osteoclastoma showing a classical eccentric lesion in the epiphysis in a skeletally mature patient. This is soap bubble appearance of a giant cell tumor or osteoclastoma. Okay. Now, where do we see chicken wire calcification? That is seen in case of a chondroblastoma. Remember, chondroblastoma, another tumor which is seen in the epiphysis before skeletal maturity. also called as a Codman's tumor, isn't it? It's also called as a Codman's tumor. Okay? Onion peel periosteal reaction. Onion peel periosteal reaction is what is seen in case of a Ewing sarcoma. Ewing sarcoma. Ewing sarcoma. And sun ray appearance is classically seen in osteosarcoma, which is new bone forming around the lines of the blood vessels. Okay, so that is a sun ray or a sunburst appearance, which is seen in case of osteosarcoma or osteogenic sarcoma. Osteosarcoma or osteogenic sarcoma. Very good. Okay. Next question. So the next question to all of you is, yes. So a patient presented with an injury to the arm due to a fall from the height. X-rays were taken, revealed a fracture, which was managed operatively with plates and screws. So there is a fracture in the arm, most probably a humerus fracture, which was fixed by the surgeon with plates and screws. Careful examination showed inability of the patient to actively dorsiflex. So the patient was unable to actively dorsiflex, which means what? The patient had a wrist drop deformity. So patient had a wrist drop deformity. Which muscles were paralyzed in this pattern of injury? Which muscles were paralyzed in this pattern of injury? Please, I will request all of you to read the question carefully before start answering. There is no competition going on here. Please read the questions carefully. I have tried to make up simple questions with a clinical tinge so that these can come in the examinations, so that it doesn't really bother all of you. Yes, the patient has a wrist drop deformity. So the splint here, which all of you can see, is also being given according to that. This is a classical diagram of a dynamic cock-up splint. Dynamic cock-up splint. Dynamic cock-up splint. And now, most of you have got this right, I think, initially. This is a dynamic cock-up splint. This is a dynamic cock-up splint which is used for wrist drop deformity. And why does a wrist drop deformity happen? Because the wrist extensors get paralyzed. The patient is not able to actively extend. So what are the wrist extensors? Extensor carpi radialis longus and extensor carpi radialis brevis. So this is the answer for this. This is the answer. Extensor carpi radialis longus and extensor carpi radialis brevis are the group of muscles which become paralyzed. Why? Because in fracture of the humerus shaft which this patient has undergone, most probably the nerve which gets involved is the radial nerve. As a result of which patient develops a wrist drop deformity. You give a cock-up splint, which is, as you can see in this picture, till the time the nerve is recovering, and this deformity happens because there is paralysis in the wrist extensors. Okay. Now, paralysis of wrist extensors lead to wrist drop deformity. Paralysis of lumbricals and interossei. Paralysis of lumbricals and interossei, especially the lumbricals, leads to a claw hand deformity. Yes? Claw hand deformity, which is seen in case of an ulnar nerve injury. Yes? And what is the splint which you use there? As somebody mentioned here, the splint which is used in case of claw hand deformity is what is called as a knuckle bender splint. Knuckle bender splint. A knuckle bender splint. A knuckle bender splint. ठीक है? A knuckle bender splint. ठीक है, is this clear? Right. The next question. So the next question is again a clinical scenario with a clinical picture here. So a 30-year-old male patient comes to the ER emergency with history of trauma and pain in the left hip. And as all of you can see here, left hip in an attitude of flexion, abduction and external rotation. Flexion, abduction and external rotation. Flexion, abduction and external rotation. What is the most likely diagnosis? What is the most likely diagnosis? What is the most likely diagnosis? Very good, Mudit, very good, Khushbu, very good. I think most of the students and doctors have got it right. I am very, very happy. I think most of you have done your orthopedics perfectly fine. So Saif, Khush, I think almost everybody has got it right. This is a clinical picture of anterior hip dislocation. Anterior hip dislocation. So all of you can see here, the left hip is in an attitude of flexion, abduction and external rotation. This is classically anterior hip dislocation. Anterior hip dislocation. And long-standing anterior hip dislocation, which nerve does it press? It presses the femoral nerve. Okay? Femoral nerve. Okay? Now, about posterior hip dislocation. So all of you know posterior hip dislocation. The attitude after that is that of flexion, adduction plus internal rotation. Yes, flexion, adduction and internal rotation. It presses onto the sciatic nerve. And long-standing cases can cause a foot drop deformity. Foot drop deformity. And when it causes a foot drop deformity, what splint will you give the patient? When it causes a foot drop deformity, you basically give AFO or ankle foot orthosis to the patient. Ankle foot orthosis to the patient. And what kind of injury is posterior hip dislocation also called as? Which is called as a dashboard injury. It's called as a dashboard injury. It's called as a dashboard injury pattern. Presses onto the sciatic nerve, causes foot drop. And what is the splint which you give in a foot drop deformity? It is an ankle foot orthosis or an AFO. AFO, ankle foot orthosis or AFO. And this is also called as a dashboard injury. Now, the other two choices as far as the fractured neck of the femur is concerned, the fractured neck of the femur causes a mild external rotation and shortening, while intertrochanteric fracture causes exaggerated external rotation and shortening. Okay, so this is how, just by observing the attitude of the patient. So if you have a patient with a lower limb in flexion, abduction, external rotation after a trauma, consider excluding anterior hip dislocation. If there is just an external rotation deformity which is limited, which means that the lateral part of the foot is not touching to the couch, old osteoporotic patient, consider excluding fracture neck of femur. In a young patient with a traumatic injury to the hip, if there is an attitude of flexion, adduction and internal rotation, consider posterior hip dislocation, because posterior hip dislocation is the most common type of hip dislocation, right? And finally, in an old patient, osteoporotic patient, if you see very severe external rotation deformity such that the lateral part of the foot touches the couch, then consider excluding a intertrochanteric fracture. So most common type, you're absolutely right. I think Dr. Knight is written, most common type of hip dislocation is posterior hip dislocation. Most common type of shoulder dislocation is anterior shoulder dislocation. Most common joint to dislocate in the body is shoulder joint. Most common joint to dislocate in the body is shoulder joint. Okay. Now, the next question. The next question. So the next question, the 15th one, is a 50-year-old middle-aged male patient falls on his knee as a result of a slip on the staircase. So falls on the knee. X-ray of a patient shows a fracture. Which is the best treatment for this? So first choice is open reduction and internal fixation with a plate. Second is open reduction and internal fixation with a tension band wiring or TBW. C is closed reduction and cylindrical cast application. And fourth is use of an external fixator. Okay. Now, so I think most of you, Dr. Priya is right, Afzal is right, Dr. Saif is right. I think most of you have got this right as well. This is a patella fracture, as all of you can see here. This is a fracture of patella. Okay. Now, patella, this is a patellar fracture, and the treatment of choice for patellar fracture is an open reduction plus internal fixation with the use of tension band wiring. Okay, tension band wiring. What are the other fractures for tension band wiring? You use this for olecranon fractures, and rarely do we use this also for medial malleolus fractures. So now, so somebody is asking, Dr. Mudit is asking, closed reduction and cylindrical cast application. Okay, so Mudit, if you can see here, we say patella is a sesamoid bone in the tendon of quadriceps femoris, and to understand this, see the amount of pull which is there. Okay, and patella integrity is very, very important for the patient to have a proper extension or extensor mechanism functioning. If you have this much of a gap, as you can see here, it won't be possible for you to do an adequate closed reduction and maintain this. And if there is a patellar gap and the patella is disrupted, then the patient will always have a difficulty in extension, or what is called as an extensor lag. So the best treatment for this would be to open, reduce anatomically, and then fix with a tension band wiring. So the answer for this would be a tension band wiring. The answer for an undisplaced patellar fracture would be a cylindrical cast application. The answer for an undisplaced patellar fracture would be a cylindrical cast application, but the answer for this here would be a tension band wiring. Okay, is this clear to everybody? And tension band wiring, please remember, also done in case of olecranon fractures and sometimes in case of medial malleolus fractures as well. Okay, now the next question is again an image which I have put in the examination in this question, is an X-ray which shows here which important kind of fracture dislocation is this? Which important kind of fracture dislocation is this? I think most of you identify, and yes, I think most of you identify this correctly. This is very, very encouraging for me to know. Very good, children. Very, very good. Now, this is an X-ray which shows fracture of, this shows fracture of the upper 1/3 of ulna and along with this, presence of a radial head dislocation, this is Monteggia fracture dislocation. This is Monteggia fracture dislocation. Fracture of the upper 1/3 of the ulna, which all of you can see here. Okay? And all of you can also see the radial head has come out from its articulation with the capitulum. So radial head dislocation. This is what is called as a Monteggia fracture dislocation. Monteggia fracture dislocation. Okay. So what are the other three which are mentioned here? What is Galeazzi? Galeazzi fracture dislocation is fracture of the distal 1/3 of the radius plus an injury to the distal radioulnar joint. An injury or separation of the distal radioulnar joint is Galeazzi fracture dislocation. So fracture of the radius, lower end of radius fracture along with opening of the distal radioulnar joint, that is Galeazzi fracture dislocation. No, Mudit, both bones don't break. In Monteggia, the primary fracture is that of ulna. In Galeazzi, the primary fracture is that of radius. Okay. What is Essex lopracity fracture dislocation? What is Essex lopracity fracture dislocation? Essex lopracity fracture dislocation is an injury primarily at the elbow. So it is a radial head fracture. It's a radial head fracture. And the injury is such that the force gets transmits through the interosseous membrane, goes all the way down, and it opens up the distal radioulnar joint. So, radial head fracture around the elbow along with distal radioulnar joint injury is what is called as an Essex lopracity fracture dislocation. So radial head fracture along with an injury to the distal radioulnar joint or a separation or a subluxation is what is called as an Essex lopracity fracture dislocation. Essex lopracity. And finally, the Bennett's fracture dislocation is a fracture dislocation at the first carpometacarpal joint. So nothing to do with the forearm. Bennett's is actually in the hand. So when there is a fracture of the base of the first metacarpal, when there is an intra-articular fracture of the base of the first metacarpal, along with this, there is a dislocation of the first carpometacarpal joint, that is what is called as a Bennett's fracture dislocation. So what is Bennett's? Bennett's fracture dislocation is an intra-articular fracture of the base of the first metacarpal, and along with this there is a subluxation of the first CMC joint. First CMC means carpometacarpal joint. This is what is called as a Bennett's fracture dislocation. Yes, Dr. Prashant is asking, interosseous membrane rupture present in Essex? Yes, interosseous membrane injury is in Essex lopracity fracture dislocation. All of these options which I have given here are types of fracture dislocations, and they are the ones which are also commonly asked in the examination. So, all of you must be well aware of this. Now, one more question comes from here. So, Rolando's fracture, Dr. Abdul is asking. Dr. Abdul, Rolando is a fracture of the base of the first metacarpal, but there is no associated subluxation or dislocation of the carpometacarpal joint. So it is just a fracture, not a fracture dislocation, Rolando's fracture. Now, since Monteggia fracture and Galeazzi are types of fracture dislocations, both of them are called as, so both of them, Galeazzi and Monteggia, are called as fractures of necessity. They are called as fractures of necessity. Called as fractures of necessity. Okay. So both Galeazzi fracture dislocation and Monteggia fracture dislocation are called as fracture of necessity. There is another fracture here, which is lateral condyle humerus fracture in children. So lateral condyle humerus fracture in children is also called as fracture of necessity. So if there is a fracture of necessity is something what you are asked in the examination, please remember these three: Galeazzi fracture dislocation, Monteggia fracture dislocation, and lateral condyle humerus fracture in children. All three are called as fractures of necessity. Okay, fractures of necessity. Okay, the next question is, the next question, or question number 17th, is a 60-year-old female patient fell down in the market and started having pain and swelling around the wrist region. She was taken to the hospital and managed conservatively with plaster cast application. After the plaster of Paris cast was removed, she started complaining of severe stiffness and swelling around the wrist region. X-rays were taken, showed a patchy osteoporosis. What is the most probable diagnosis here? What is the most probable diagnosis? What is the most probable diagnosis? Please don't jump into the answers. Please try to read and understand the question. Please try to read and understand the question here. Please try to read and understand the question, everybody, requesting. The question says that a 60-year-old female, so most probably an osteoporotic female, fell down in the market and started having pain and swelling. So in this age group, most commonly the fracture pattern which is seen is Colles fracture, yes? Okay. She was managed conservatively with plaster cast application. So in Colles fracture, the treatment of choice is closed reduction and plaster of Paris cast application. Yes. Now, when the POP was removed, the patient had severe pain, stiffness. As you can see in this clinical picture which has been given here, the patient has severe swelling on the dorsum and the joints have severe stiffness. X-ray shows severe patchy osteoporosis. Yes or no? What is the answer in this? What is the most probable diagnosis? So this patient had a Colles fracture which was treated by a plaster cast application, and now I think most of the doctors have got it right. So Sneka is right, Saif is right, Shrishti is right, Dr. Prince is right. I think everybody now understands what we are trying to talk here about is development of a potential complication of a Colles fracture is what is called as a reflex sympathetic dystrophy, RSD, nowadays also called as complex regional pain syndrome, complex regional pain syndrome, okay? And the answer for this is complex regional pain syndrome type 1. This is complex regional pain syndrome type 1 is the answer, which is a reflex sympathetic dystrophy or Sudeck's osteodystrophy or complex regional pain syndrome pattern which develops after a significant bone and soft tissue trauma. So the answer here is complex regional pain syndrome type 1. Complex regional pain syndrome type 1, okay? Complex regional pain syndrome type 2 develops after a direct peripheral nerve injury. A direct peripheral nerve injury, after a direct peripheral nerve injury, and which nerve is most commonly involved here is the median nerve. ठीक है बेटा, complex regional pain syndrome type 2 are the changes of stiffness and swelling and the skin trophic changes which develop after direct injury to the peripheral nerve, most commonly the median nerve. While complex regional pain syndrome are the changes because of reflex activation of sympathetic nervous system, and these changes include pain, stiffness, swelling, limitation of movements, and with these x-rays showing that significant amount of bone has been eaten away, what are localized or patchy osteoporosis, which takes place after a fracture or a significant soft tissue injury. Most common cause of complex regional pain syndrome type 1 is Colles fracture, So please remember this, complex regional pain syndrome type 1 or reflex sympathetic dystrophy or Sudeck's osteodystrophy, all are the same things. They are caused most commonly after Colles fracture, but it is not exclusive. It can happen in the foot also after a significant soft tissue injury. While a complex regional pain syndrome type 2 develops after a direct injury to the peripheral nerve, and that practically most commonly is because of an injury to the median nerve. Okay? Now tuberculosis had got nothing here, so it was just confusing, and Dinner-Folk deformity is definitely a complication of a malunited Colles fracture, but it does not cause significant pain, swelling and stiffness. So although Dinner-Folk deformity is a complication of malunited Colles fracture, but it is not associated with development of a complex regional pain syndrome. So it's not the answer here. Right? Is this clear to everybody? CRPS or complex regional pain syndrome, also called as reflex sympathetic dystrophy, also used to be called as Sudeck's osteodystrophy, is an important examination question. So all of you must understand, wherein your patient presents with pain, stiffness and swelling. Classically, the X-ray, as you can see here, if I zoom this X-ray, shows areas of patchy osteoporosis. Okay? Don't get confused in the examination. This is one which is very, very commonly asked both in screening as well as the NEET examination. Okay? Now, next question is on identification of spinal brace. This was a question in the last examination, I think, also. Correct. So identify the spinal brace which is shown below. And your choices are Ash brace. Ash is an anterior spinal hyperextension brace. Choice number B is a Taylor's brace. Choice number C is a Somai brace or sterno-occipito-mandibular immobilizer. And choice number D is Milwaukee's brace. So what is the answer here? And I think Dr. Ali is right, Dr. Priya is right, Dr. Ravi is right, Dr. Dinesh, this is not Milwaukee's. So, beta, answer here is, this is a classical diagram of a Taylor's brace. This is Taylor's brace. As you can see in the diagram, on the posterior aspect, it covers and immobilizes the thoracic or the dorsal spine and the lumbar spine. There is a belt in front and there are straps along the shoulder. So, classically used for managing thoracic and lumbar traumatic injuries like fractures and also infections, especially the tuberculosis infection of the spine. While you give anti-tubercular treatment to the patient, you immobilize by the use of this classical Taylor's brace. Okay, Taylor's brace. Ash brace is called as an anterior spinal hyperextension brace. The anterior spinal hyperextension Ash brace is a dynamic brace wherein we give this brace with an anterior support to a patient such that the spine does not tilt into a kyphosis. So it's a dynamic brace. It not only prevents kyphosis formation, it also is a corrective brace. So anterior spinal hyperextension is a dynamic brace. Now as far as the SOMI brace is concerned, it is a occipito-mandibular immobilizer, which is used, as somebody is saying, which is used in case of a cervical spine immobilization, which is used in case of cervical spine immobilization. And Milwaukee's and Boston's brace are used for correction of scoliosis. Okay, they are used for scoliosis. Milwaukee's and Boston's brace are spinal braces which are used for correction of scoliosis. Okay, but answer here is Taylor's brace. Taylor's brace. Now next question is another X-ray. And although questions are not necessarily always coming from images only, but I wanted this session to be only image based so that there is this last minute confusion in students' minds about the various images and X-rays can get cleared in this discussion. So, okay, X-ray of picture shown below, diagnostic of. So I'll just zoom this. It is an X-ray of the shoulder joint. X-ray of the shoulder joint, and your choices are, is it anterior shoulder dislocation? Is it posterior shoulder dislocation? Is it inferior shoulder dislocation? Or is it a recurrent shoulder dislocation? Recurrent shoulder dislocation. So Dr. Ravi has got it right. Dr. Stuffy has got it right. Very good. I think it is very encouraging to see that some of the students here already know this is a classical radiological sign which is seen in patients with posterior shoulder dislocation. So when they fall and when this head of the humerus goes back, there is an internal rotation of the humeral head such that because of this internal rotation, it appears like a light bulb. So this is what is called as a light bulb sign. This is called as a light bulb sign which is seen in posterior shoulder dislocation. Posterior shoulder dislocation. Posterior shoulder dislocation. So the answer here is this radiological sign is called as a light bulb sign in posterior shoulder dislocation. Remember friends, posterior shoulder dislocation is called as the dislocation of 3 E's. So you see patients in epilepsy, patients on electroconvulsive therapy, and patients of electrocution. Okay, so patients who suffer these electrical shocks or epileptic seizures, they tend to fall down, as a result of which the head of the humerus goes back and then it causes a posterior shoulder dislocation. Posterior shoulder dislocation. The attitude of the limb in posterior shoulder dislocation is that of internal rotation. The attitude of the limb. Yes, very good. Dr. Abdul is absolutely right, beta. There is also one more sign here called as an empty glenoid sign. Very good. Very, very good. So there are two signs in posterior shoulder dislocation, a light bulb sign, also an empty glenoid sign. So very, very good. I am very happy with this. Very nice. Now in anterior shoulder dislocation, please remember a few points about anterior shoulder dislocation before you go for your examinations. So the anterior shoulder dislocation So attitude of the limb, it is the most common type of dislocation. Okay? It's the most common type of dislocation, and in the various kinds of anterior shoulder dislocation, the most common type of anterior shoulder dislocation is the one which is, so it can be just a preglenoid type, it can be subcoracoid, but one in which the head of the humerus is placed below the coracoid process. So it's called as a subcoracoid types. Okay? That's the second important thing. And the attitude in case of, the attitude of the limb will be that of abduction plus external rotation. Abduction and external rotation. Abduction and external rotation. Subcoracoid types, and the attitude of the limb will be that of abduction and external rotation. Okay? Now, in case of inferior shoulder dislocation, what is inferior? Inferior means that the head of the humerus is present below the glenoid. So, patient comes with the hand which is hyper abducted. So, the attitude of the limb in case of inferior shoulder dislocation is that of hyper abduction. Hyper abduction. Hyperabduction. And what is recurrent shoulder dislocation, beta? Recurrent is when this head of the humerus keeps on coming out anteriorly. So 3 or more dislocations of the same joint is recurrent shoulder dislocation. And recurrent shoulder dislocation, as all of you can remember, characterized by 2 important pathological signs. The most common is the Bankhart's lesion. Okay? Which is an antero-inferior glenoid labrum tear. And the second one, which is called as Hill-Sachs lesion. A second one which is called as a Hill-Sachs lesion, which is a defect in the posterolateral part of the humeral head. Posterolateral part of the humeral head. Very good. So this is most important points about the concept of shoulder dislocation. Okay, next. A few questions from peripheral nerve injury now. Now, the next question is that the patient came in the hospital and was being evaluated for a suspected injury to the peripheral nerve. Suspected injury to the peripheral nerve. He was asked to form a closed fist, but on the involved side, he was unable to flex his fingers completely. Unable to flex his fingers completely. Which nerve is involved in this patient? What is this sign? As all of you have written it absolutely correctly. This is what is called as a pointing index test. Pointing index test. Okay? When you ask the patient to make a fist, on the involved side, the index finger remains extended or prominent, as all of you can see here. It is because of paralysis of the flexors for these interphalangeal joints, which is flexor digitorum superficialis and flexor digitorum profundus, both of which are supplied by median nerve for the index finger. So the answer here is median nerve. Answer here is median nerve. This is called as a pointing index test, also called as Ochsner's clasp test, also called as hand of benediction. Hand of benediction. Okay. So median nerve is the answer for this. There is a classical pointing index test, pointing index sign. Very good. I think all of you have got it done, got it absolutely correct. This is pointing index test. Now next question. Next question, also an easy one. It's just for a purpose of recapitulation that we've got them. So the next question is, that the patient is asked to hold a book. Patient is asked to hold a book between his thumb and the index finger. The examiner was able to see a prominence of the thumb interphalangeal joint of the right hand. So this is your right hand. This is your right hand. Okay. So you see a prominence here. You see a prominence of the thumb interphalangeal joint, which you are not able to see on the left side. Okay. So examiner was able to see a prominence of the thumb IP joint at the right hand shown in the picture. Which nerve is involved in this patient? Which nerve is involved in this patient? So beta, when you ask a patient to hold a book between the thumb and the index finger, normally we use which muscle to hold the thumb? It is the use of adductor pollicis normally, which the patient is using here, Okay, so left side, patient is using adductor pollicis to adduct and hold the thumb. So adductor pollicis, if you remember friends, is the only thenar muscle which is supplied by ulnar nerve. Now, in case the patient has an ulnar nerve palsy, and you ask a patient to hold the book in the similar way, see what happens. Instead of adductor pollicis, which is paralyzed, patient holds the book but substitutes by the use of flexor pollicis longus. This is a test which is called as a book test, also called as Froment sign, and the nerve and the muscle here which are involved is adductor pollicis, and the nerve is an injury to the ulnar nerve. It is an injury to the ulnar nerve. This is Froment sign, and a very, very important question from the examination point of view. Very important question from the examination point of view from the ulnar nerve is Froment's sign. Okay, is this clear? So patient uses flexor pollicis, and most of you have got this absolutely right, so I don't want to name everybody. I think all of you know this. This is a very, very encouraging sign for me before the examination. Okay. Now next question, or question number 22nd. Yes, Dr. Abdul is absolutely right. Knuckle bender splint, as I told you previously also, is a splint which is used in patients with an ulnar nerve palsy and a claw hand deformity. Okay. Now the next question to all of you is a question number 22nd, which is a patient who is 72 years old, osteoporotic female patient, presented in the hospital with complaints of pain in the thigh with inability to bear weight on the affected side, and x-rays were taken and showed a fracture. What is the most probable cause of this fracture? Please everybody, do not jump into answers. Try to understand what the examiner is asking. Please do not jump. Please try to see what the examiner is asking. I think most of you are getting it wrong, so please try to read what we are trying to ask you. A 72-year-old osteoporotic female patient presented with a pain in the thigh with inability to bear weight on the affected side. Osteoporotic patient means that the patient is on anti-osteoporotic treatment. Yes. One of the most common medicines used are bisphosphonates. And all of us know that long-term use of bisphosphonates are implicated in causation of these classical fractures in the region of subtrochanteric region. These are what are called as atypical fractures. Atypical fractures. So the answer here is the most probable cause is atypical fractures due to chronic use of bisphosphonates like alendronate, ibandronate and risedronate and zoledronate. these are fractures in the subtrochanteric region of femur. So these are called as atypical fractures. For patients who have taken long-term bisphosphonate therapy, classically more than 3 years, is what results in atypical fractures, okay? So easy question if you read the answer very carefully. If you don't read, everybody will mark osteoporosis here, but the clue here in this answer is because we have already mentioned that a 72-year-old osteoporotic patient has presented to you, which means that the patient is a known case of osteoporosis, which means that the patient is already on treatment for osteoporosis, which is bisphosphonates. Is that right? So atypical fractures due to long-term bisphosphonate is exactly how the patient presents to you with. Excellent. So the next question is, okay, now see this image carefully, and most of you already know the answers. Absence or delayed. I have intentionally put this question today because before the examinations, I want everybody to know what rickets is. So, absence or delayed appearance of epiphysis, widening of the growth plate of physis, and cupping and splaying of the metaphysis classically are 3 important X-ray descriptions definitely of a patient with rickets, okay? So, absence or delayed appearance of epiphysis, as a result of which increase in the width of the physis or the growth plate and the pressure resulting in cupping and splaying of the metaphysis. Cupping and splaying and fraying of the metaphysis is what is classically seen in patients with rickets. And in India, everybody knows nutritional rickets is the most common cause or form of rickets. Scurvy, all of you know, scurvy is characterized by a few radiological important signs which we all covered in image-based sessions. So, scurvy is deficiency or lack of vitamin C. So, you have important signs like you have a Wimberger's ring sign, which is calcification around the margins of the epiphysis. Then you have a white line of Frankel. Okay. Then you have Trummerfield's zones. Trummerfield zones, and finally you have fractures in the regions called as Pelkin's fractures or Pelkin's spur. Okay, so these are the 4 important radiological signs in a patient with scurvy. Lack of vitamin C. So Wimberger's ring sign or Wimberger's ring epiphysis, white line of Frankel, Trummerfield zone, so radiolucent zones under the zone of provisional calcification, and Pelkin's spur of fracture. 4 important radiological signs. Hyperparathyroidism. What does hyperparathyroidism do? So when there is a tumor, it causes excess of PTH secretion, it causes recruitment of osteoclast and bony resorption. So what is the important landmark X-ray finding in primary hyperparathyroidism is your subperiosteal resorption of phalanges, Brown's tumor of hyperparathyroidism, and lastly a salt and a pepper appearance of skull. I am so very happy that most of the students are answering almost all the questions correctly. So I am extremely confident that all of you are very, very well prepared before the examinations, because I am getting the answers which I wanted to listen in this class. extremely encouraging this before the examinations, that most of you have done your orthopedics well, have revised the orthopedics well, and are now appearing. It appears as if you are extremely confident before your examination. So I expect all of you to do well as far as ortho is concerned, okay? So these are the important things as far as these important metabolic bone diseases are concerned. Now next, so the penultimate, last but one X-ray or question. Is a clinical question which is based upon a patient who is 37-year-old male patient, is presented in the outpatient clinic with severe pain in the lower back, along with a progressively increasing stiffness, where X-rays were taken of the pelvis and revealed the following findings. What is the most probable diagnosis here? What's the most probable diagnosis here? What is the most probable diagnosis? And this is, I think everybody understands this X-ray. This is very, very encouraging. This is X-ray of the pelvis, anterior-posterior view. And if there is one finding which I want all of you to see, and I probably think all of you have already seen this, is a classical sclerosis. Classical sclerosis of the sacroiliac joints, which is the first finding in a patient with ankylosing spondylitis. So, ankylosing spondylitis, it is a seronegative spondyloarthropathy, but still the patient is positive for HLA-B27. Okay, the patient has this sclerosis of the sacroiliac joint. Enthesopathy ultimately results in a bamboo spine formation. So, I think almost all of you have got this absolutely right. This is an X-ray from a patient with ankylosing spondylitis. Okay? The first and the most common joint involved is the sacroiliac joint. Remember this, in contrast with rheumatoid arthritis, which is commonly seen in females. Yes, it is seropositive, which means RA factor is positive in case of patients with rheumatoid arthritis, and involves the appendicular skeleton more than axial. So, most common joint involved in rheumatoid in females is your metacarpophalangeal joint of the index finger. And all of you know, are aware about the deformities like swan neck and boutonniere and Z deformity in rheumatoid arthritis. So, these are two important topics from your inflammatory arthritis which come through with the questions, definitely come in the examination. So, you must be aware in rheumatoid arthritis and ankylosing spondylitis, there are two important inflammatory arthritis and involvement of joints which are very, very commonly asked in the examination. Okay? The final question for today would be again an X-ray. Would be an X-ray just to identify what is this. So, you have an X-ray of the foot, an antero-posterior view and an oblique view, shows an fracture which is marked by a circle. Okay, what is the diagnosis here? What is the diagnosis here? What is the diagnosis here? So, all of you can see here an X-ray of the foot shows fracture base of the fifth metatarsal, fracture of the base of the fifth metatarsal, an injury in the zone 2 region of the base. We will not go into detail now, but zone 2 injury, very commonly seen in athletes, is what is called as a Jones fracture. It's called as a Jones fracture. It's called as a Jones fracture. It's called as a Jones fracture, and because of the pull of abductor brevis tendon, peroneus brevis tendon, it basically these fragments remain apart from each other, and therefore sometimes these displaced fractures need to be fixed as far as the treatment is concerned, very commonly seen in sports. Now what is a March fracture? Just to conclude and tell you, March fracture is a stress fracture of the second, which is most commonly, or the third metatarsal of the foot. Okay, a stress fracture of the second or the third metatarsal of the foot. और अगर दोनों एग्जाम में, if both the choices are in the examination, please mark the second metatarsal. Most commonly third metatarsal, rarely. That's called as a March fracture. Very commonly seen in patients who are regularly stamping their foot. So dancers, army recruits, professional long distance runners, and these are the people. So that's called as a March fracture. So stress fracture of the second or the third. What is Lisfranc's fracture dislocation? What joint is a Lisfranc joint? Lisfranc is a fracture dislocation which is seen at the tarsometastarsal joint. Okay, so Lisfranc's joint is the tarsometatarsal joint. Tarsometatarsal joint is called as a Lisfranc's fracture dislocation. Lisfranc's fracture dislocation is fracture of the tarsometatarsal joint, fracture dislocation. And lastly, what is aviator's fracture? Aviator's fracture is a fracture of the neck of talus. Fracture of the neck of the talus, which is very, very commonly seen in patients who are in aviation industry. So fracture neck of the talus, it's called as an aviator's fracture, aviator's fracture. Okay. So friends, this completes our live YouTube session before your examinations as far as the subject of orthopedics is concerned. Now, I would not hesitate to motivate all of you, but very honestly, seeing the answers which you have given to the questions today, most of you appear to be extremely well prepared for your examinations. Just I want all of you to please maintain peace and calm within your mind and don't get bothered before the examination. I am sure all of you will do very well in the examination. इस एग्जामिनेशन को फोड़ना है और हमें इसको एग्जामिनेशन को फोड़ने से कोई नहीं रोक सकता. Okay, so take this confidence in the examination. I am telling you, all of you are very well prepared. I have got most of the correct questions, answers from all of you. So from the deep aspect of my heart, I wish all of you great success, not only in this examination, but in your future professional career also. So please take care. Good night to everybody. Do well in the examinations and don't hesitate or feel afraid to contact us at any point of time. So wishing all of you all the best. I see off from you. Good night.